involvement, in case of mandible involvement, I prefer surgery primarily. And if the mandible is not involved, then we can try the concurrent chemoradiation, but the concurrent chemoradiation setting is all or none settings. So if it's successful, it's good, but if it fails, the patient may lose their life. So in the point of view, that's why we try induction chemotherapy as an initial treatment, and according to the response, we can use the induction chemotherapy as a biomarker for the response to the non-surgical treatment. So then we can evaluate the tumor response. Then we can go to the surgery, or we can go to the radiation also. So our results with this principle that surgery arm showed much better survival than radiation therapy arms.
Reconstruction. There are difficult, this is a difficult task and different measures how to achieve reconstruction, but still we have to realize that what we bring in, it's tissue of this patient, but we don't have mobility, we don't have sensitivity. So how do you deal with these problems? Do you try to get in as much as tissue as possible? And what's the result for speech and swallowing? Or do you try to keep the tongue in particular as mobile as possible, so that you perhaps may even consider to do no reconstruction or primary closure at all? Because this is what we have learned from laser surgery, that of course you can leave these wounds just to heal in secondary intention. So what are your experiences?
Well, of course we have to give as much mobility as possible, in particular for the tongue lesion. So our preference, but it is institutional preference or the plastic team preference, and we have to discuss with them, but our preference will go for a free flap of the antebrachial area, the so-called Chinese flap, in order to cover sufficiently the defect, but you don't bring in too bulky flaps like was done in the past with the pectoral major, because you need to have this mobility of the tongue, and being able, the patient has to be able to do what he has to do in chewing, swallowing, and speaking with the rest of the tongue. So the rest of the tongue is doing the job, and the free flap is following. Even if it's not innervated, he's filling in the gap and giving some mobility, yes. If you have to use a peroneal flap, then you have to bring also composite flaps with the bone and soft tissue and skin to cover, and you may achieve good results as well. But Chinese flap will be maybe the best one.
Best choice. Dr. Kim?
Yeah. When the tumor size is not so big and the resection is less than hemiglossectomy, I prefer primary closure if possible. But it's bigger than a hemiglossectomy. The reconstruction is inevitable, and in case we resect the tumor intraorally and neck dissection is done, then we could use the radial forearm flap. But if we have to open the mandible, then and we have to resect the mandible, then we have to use the fibular free flap. That's my favorite one.
Mm-hmm. Total glossectomy, still an issue. Sometimes you have patients with really gross primary disease and perhaps very little or even no evident nodal disease. And apparently you have the impression, well, of course we can do primary conservative treatment, but you don't have a very good feeling with it. So do you sometimes, in special indications, still perform total glossectomies?
Well, it depends on what you call total glossectomy. If you can leave a little bit of the base of the tongue and innervation with it, if the patient is well reconstructed with a forearm flap, he will still be able to act with the rest of the muscle of the tongue, and with a good team of free elocution, he will be able to swallow. Maybe he will have a trach for a long time, or maybe forever, but he will be able to have a better social life. Now, if you have to do a removal of the entire tongue, sometimes for oncologic reason also you have to take out the larynx. So that is another story. Those are very, very advanced tumor, and if you don't do it properly, you are ruining the chance of the patient, because you are leaving maybe some nest of cells behind in the pre-epiglottic space or whatever.
Right. But nevertheless, in special cases, you would still consider this to be an appropriate approach.
Yes.
Dr. Kim?
As far as the tumor is confined to the soft tissue, then it's better to try the chemotherapy first instead the primary total glossectomy. And if you have to do total glossectomy, I preserve the larynx as possible as I can. But if the tumor is into the tongue base, I think the larynx should be removed.
Yeah.
And these are definitely cancers that we would treat with a combined modality chemotherapy approach, as I would agree with Dr. Kim for this type of cancer.
So oral cavity cancer is readily accessible for intralesional or local treatment approaches. So you have already mentioned shortly brachytherapy, which is a really institutional preference, to my impression at least. So we don't have any experience with it. And we have sometimes intralesional treatment approaches. Intraarterial chemotherapy is super selective via arteria lingualis. So in Baltimore, do you make any preference on this particular site in type of real local treatment?
Well, I have experience from actually 20 years ago with intraarterial chemotherapy for these types of lesions, and then of course more recently there's been more investigation of intraarterial chemotherapy in the super selective approach. It does work. It does shrink the tumors. But there have now been randomized controlled trials that show that it's that the results ultimately are not better than giving systemic chemotherapy, which is much easier in terms of just the technical group that you need to be able to do these super selective procedures. So that's not something that we do in Baltimore.
Mm-hmm. Do you have any experience with?
When I was it was a long time when I was a resident, we tried intraarterial chemotherapy through superficial temporal artery for the maxillary sinus cancer and also oral cavity cancers. And usually we used a 5-FU and methotrexate. And the result was quite good at the time. But after we have the medical oncology teams, they didn't like this intraarterial chemotherapy. They prefer the systemic chemotherapy, and they insisted that the effect is almost same. So since then, we didn't do any intraarterial chemotherapy.
Yeah, it's something that's it's come in and out of vogue, I think, over a long period of time.
How about photodynamic therapy? It's a little bit similar to coming into vogue and out, in particular for smaller lesions. Experience, ideas. So I've never performed it in these patients, but you read, of course, a lot of enthusiastic reports on it.
It's not something that I have experience with at my institution. I think it, you know, the interesting phenomenon that we're seeing in the United States is an increase in incidence of oral cancers in younger people under age 45. That's not related to the human papillomavirus. It appears to be only about 5% of cases are HPV positive. I don't know if that's going on in Europe as well. And so we have this whole issue of premalignancy and how one deals with these multifocal types of cancers in the non-smoker. And perhaps there's a role for photodynamic therapy in that group.
Right.
Photodynamic therapy can be indicated for very superficial lesions only. So this is only T1 cases usually. So in intraoral cancer, oral cavity cancer is very easy to access. So the photodynamic therapy setting is rather complicated and takes a long time. So it's better to do with the surgery. But if the tumor is in the bronchs or in the trachea, then it's very difficult to access and needs a big surgery. And even if the tumor is very superficial and small. So in the case, the photodynamic therapy may be indicated, and I think it's used in some institutes too.
Right. So we are coming to the end of our discussion round. Final conclusion, for example, would you perhaps agree that in particular the site of oral cavity, that their surgery probably has a stronger part to play as, for example, what the discussion will be in larynx? Do you agree on this perhaps? So do we have the impression that conservative treatment in the oral cavity cancer is perhaps not as effective as in other sites of the head and neck?
I think that it's really based on the fact that these patients can be treated pretty well with good function and good, good outcomes, reasonably good outcomes with a surgical approach. I do have to add the caveat, though, that now that we are expanding the number of drugs that we have available, we have biologic drugs, and so hopefully, hearkening back to some of the discussion yesterday in terms of trying to identify prognostic markers and molecular markers, that we can target some of these patients for other types of therapies. So I don't think they should be automatically excluded from clinical trials and systemic therapies.
Yeah, oral cavity cancer is a rather aggressive cancer, although in an early stage, if we fail to treat them, the patient lose their life. So we must be very careful, and we have to use all kind of options we can use. So the best modality is not, there is no best modality for these cancers. So we have to design the treatment modality according to the patients and the patient status and also their economic status also. So we have to customize all the treatment modality, I think.
So if you have oral cavity cancer, you have one real chance, and you have to look for a good surgeon, a good radiotherapist, and a good oncologist, right? Okay.
And a good pathologist.
Thank you very much.
And a good pathologist.
Good pathologist. Okay. Thank you very much.